Thank you so much, Dr. Ashish Sharma, for your kind words, and thank you to Dr. Biswas, Partha Biswas, for his kind invitation as well. Although I was given a very generic talk of retinal vein occlusion, I thought I would modify my talk to fit in with the flavor of what's been discussed now. Is basically cost-benefit analysis, and it's not just developing countries like India, but cost is something that affects every country. As Dr. Sharma has rightly pointed out, our first-line management now is Ongavia. So the difficulty we have is of switching patients who have previously been on Lucentis to Ongavia, whereas it's not difficult starting a patient on Ongavia. If somebody is stable on Lucentis, it's more difficult to justify switching that patient onto Ongavia.
So just sorry to interrupt. Ongavia is a different name, but it's the same molecule FYB201. Means BioVis, which was a molecule from Samsung Biopsys, that has the same name across the globe, BioVis. But Ongavia that sir is talking about is the molecule FYB201, which has different name in different countries, and Ongavia is the one which they call it in UK. Sir is from UK.
Yes, I mean there are 3 biosimilars that are available, and like most drug manufacturers, different names are given in different countries. So yes, it is a ranibizumab biosimilar. So I'm not going to talk much in general about retinal vein occlusion, because I think this is something that you all will perhaps all know about. Is the second most common cause of vascular related visual loss, retinal vascular related visual loss, apart from second to diabetic retinopathy. I'm not including AMD specifically in that. And there are broadly 2 categories, perhaps 3 if you include hemiretinal vein occlusion, but basically they are branch retinal vein occlusion and central retinal vein occlusion. And here we're specifically talking about the macular edema associated with retinal vein occlusion to fit in with the flavor of the talks that we have had previously. So fluid leakage in the retinal vessels is not just a mechanical effect. It's not like a hose pipe you clamp at one end and the pressure of water makes fluid to leak out from little holes in the tube. But it's a very complex underlying vascular and inflammatory pathologies that are involved. And we've seen that there's upregulation of vascular endothelial growth factor and various cytokines in retinal vein occlusion. We've been discussing that the management basically consists of intravitreal injections. And we basically have a choice of 2 broad categories of intravitreal injections. Either an anti-VEGF agent, and here I'm talking only about the NICE approved, NICE's National Institute of Clinical Excellence, which is an approval body in the UK. So either ranibizumab or aflibercept, and that includes ranibizumab biosimilars as well, or the steroid dexamethasone. So in terms of cost-benefit analysis, how do you choose what to use as first line? Do you want to try anti-VEGF and see whether that works? And if the anti-VEGF, after 3 injections, you get absolutely no clinical benefit or OCT benefit, or you get partial benefit and you want to try maybe 6 injections before you switch? Or do we switch early on? Or do we start with a steroid? And that is the question. In all situations, one thing to think about is the drug cost. But perhaps a larger proportion of money goes towards the service cost. That is paying for my time, paying for the nurse's time, paying for the receptionist's time, paying for the person who pulls out the notes. So that is the overall cost. So by decreasing the number of visits, we can perhaps decrease the overall cost burden of treatment. So it's not just the drug cost that one needs to think about. So can pre-treatment assessment of aqueous biomarkers help guide management of these patients? And this was financed by, it's called the P2P grant, a University Health Board grant. The aim was to measure the level of vascular endothelial growth factor and inflammatory cytokine IL-8 in the aqueous humor of human controls, branch retinal vein occlusion and central retinal vein occlusion. And we compared the levels of these biomarkers, compared branch vein occlusion versus central retinal vein occlusion, to see whether this really helped us with a choice of treatment. So it was a very, very small pilot study of 30 patients where 100 to 200 microliters of aqueous was collected from the anterior chamber. There were 10 patients who were undergoing routine cataract surgery in those patients who had no retinal vascular disease, so it excluded uveitic cataracts. It excluded cataracts in patients who have had treatment for AMD or diabetic retinopathy or retinal vein occlusion. So basically, squeaky clean cataract. So we felt that that could be taken as a baseline. And 10 patients each of branch retinal vein occlusion and central retinal vein occlusion. The aqueous samples were frozen immediately at minus 80 degrees centigrade until they were analyzed. And we used the ELISA technique on the Luminix MacPix analyzer using the double sandwich technique of indirect immunoassay. In terms of the vascular endothelial growth factor, because it was a small sample size and we found that the values were quite variable. Looking back into previous studies, there were a large variation in what various studies considered as controls. And therefore, rather than taking the mean, which can sometimes give a very skewed perception because you might have one very large outlying value, we thought we'd take the median as a better marker of the true value. So we found that these values are in picograms per milliliter. Control 62, central retinal vein occlusion 141, and branch retinal vein occlusion 85. So the difference between the controls, which is cataract patients, and central retinal vein occlusion was statistically significant. However, there was no statistical significance between the controls and branch retinal vein occlusion. Likewise, when we analyzed branch retinal vein occlusion and central retinal vein occlusions, the VEGF values were much higher, statistically higher in central retinal vein occlusion as compared to branch retinal vein occlusion. This is just a different way of depicting the same data where you see the central retinal vein occlusion really had much higher values than the control and branch retinal vein occlusion. In terms of interleukin-8, the control values were very small. Central retinal vein occlusion was much higher. And in branch retinal vein occlusion, it was higher, but not as high as central retinal vein occlusion. But both the central retinal vein occlusion and branch retinal vein occlusion, the levels were statistically significant. And likewise, comparing branch retinal vein occlusion to central retinal vein occlusion, and that difference was also statistically significant. And this is just a chart to show what we found. But what we found interesting is that individual values were highly variable. There were some samples where VEGF was the predominant marker. There are other values, other samples where it was not the VEGF, but the cytokines, inflammatory cytokines that were the major marker. And the same thing was true for central retinal vein occlusion and for branched retinal vein occlusion.
So just a kind request for the quick conclusion.
Quick conclusion. So
thank
the basic conclusion was the level of VEGF was higher in central retinal vein occlusion as controls, and likewise in branched retinal vein occlusion. So the question is whether we can use these biomarkers to decide which drug to use. We, of course, have had small sample sizes. Perhaps what we need to do is to increase the number of sample sizes, increase the range of biomarkers. We're taking IL-8, but there are now kits that are available that can simultaneously measure up to 27 biomarkers for the same sample size within the constraints of very, very small samples. So in short, maybe if we tested these biomarkers, we can go in directly for a drug which is perhaps the eye might respond better to.